I'm always humbled when I come to this conference, or those like it, when I hear talks like that last one and Dr. Cotton's and pretty much everybody in the audience. I kind of think, well, I'm just scratching the surface here. So I wanted to ask our panel if they could briefly just describe themselves and what they do, because we've obviously just heard a great talk from one of our panels, but the other two have not been blessing us with their talks today. So, gentlemen, could you describe who you are?
Yeah, I'm Harlan Muntz. I'm a pediatric otolaryngologist here at Primary Children's Medical Center. Currently doing some work in cleft lip and palate in the Philippines. Before that, working in India in Calcutta, and have done a lot of education stuff in South and Central America.
We know who you are.
I'm Bob Hoffman. I'm a pediatric ophthalmologist here at the university. I spend about 20% of my time training pediatric ophthalmologists in developing countries. We have active exchange programs where they come and spend 2 to 3 months with me, and then I go back and work with them. And we have active programs now in Ghana, Indonesia, Bhutan, Nepal, among other places. And I guess I'm here for about the next 3 weeks and off again to Ghana. And I've been doing that now for about the last 12 years.
So I would like to start with any audience questions. Does anybody have anything to ask this illustrious panel?
Part of our work in Mongolia, everybody knows a little bit about our work of laparoscopy, but we also take spine orthopedic surgeons with us and have been teaching and training spine surgeons in Ulaanbaatar. And it certainly is an expensive endeavor with lots of various challenges. What do you see, like say, how do you foresee orthopedic spine surgery and how we can actually make that more available for the resource poor areas of the world? What needs to happen to make that more available so that you don't have to adopt everyone?
I'm not sure. Is this okay? There it is. So our goal is to have a spine center inside Ethiopia. Dr. Boachi recently was in Ethiopia, and he said he's never seen spines like he saw in Ethiopia, both in the severity and the number. So I think that the idea of having a local center where you can do a lot of the local cases and training local people to do this is the way to start, and then you'd be able to send out the more difficult ones. But the average, say, 50 to 80 degrees that you should be able to do inside the country.
So that kind of leads into one of the questions I'd prepared earlier. Spine surgery and some of the stuff that Dr. Randall was talking about earlier, the major limb salvage and orthopedic stuff, and certainly in the world of anesthesia, we're very equipment heavy. What do you think it's going to take to stimulate the major equipment manufacturers to start making equipment specifically designed for low resource, more austere environments, not just dumbing down the fancy stuff they sell me up there, but actual stuff designed for these environments? Have at it, gentlemen.
You know, one of the things I think that's important is that if you look at it from an economic standpoint, where instead of there's certainly in the United States and most probably in the European Union, you know, the latest new thing is purchased not only for marketing but also because the surgeons demand it. But if you look at the rest of the world, where you could pick up a lot by volume, even if it's a low cost piece of equipment. And again, I have no financial relevance with the Karl Storz people, but for example, Mrs. Storz, who I've been fortunate to be able to work with them in a lot of the training programs we've had in South America and Central America. Now Mrs. Storz, who owns the company, says, I've made enough money. Let's make sure that we train people in other countries. And so, you know, right there's a big thing. And one of the pieces of equipment they have that we actually use, which is a mobile video kind of system where you can plug in your camera, use your scopes, it would be very useful in underdeveloped situations, and is relatively low cost versus what we normally use for other endoscopic kinds of things.
Well, but you and I get that, and probably most of the people in the audience get that there are those options and that the volume would make up for it. But how do we convince our equipment colleagues that that is the case? Dr. Hodes, do you have a...
Well, one of the things that we do is we use, if we don't get donations, then we use South Korean, Indian, and Chinese implants. And they're not as good as Americans, but they're often adequate, especially for the easier cases. And that's one way around that. Just like, I didn't talk about it today, but I practice pediatric oncology, and I can cure Hodgkin's disease for $1,000 using the same drugs that you'd get in Salt Lake City, except mine are Indian generic drugs. And they seem to work just as well, and they have the right side effects, that they vomit like hell and they lose their hair, and then their tumors go away.
So you know it's working, right?
Yeah.
Well,
Yeah, I think the comments about using or thinking outside the box and getting people outside the U.S. to make things like what we'd use here that are just as good for a lot less is crucial. In cataract surgery in the developing world, Aravind Eye Hospital, Tilganga Eye Institute have set up manufacturing facilities to make intraocular lens implants. They can make intraocular lens implants that are every bit as good as what we implant here. Instead of being $300 a piece, they're $3 or $4 a piece. And they make them, they won't be, why won't they approve? You can't use them here. There's no money to be made in it. But getting bright young people interested in the problems, creating a market for them so that they know there is there's going to be some future in making whatever they're doing, getting them on board. It'll take money from NGOs or philanthropists to get things started. But I think thinking outside the box and looking elsewhere for solutions is key.
yeah, I think that's a good point. That you talked about the Stewart's people and the company that I've worked with briefly from an anesthesia perspective. Both are kind of were stimulated, got their seed money, if you will, by philanthropy. It seems like that's the way to go. And then hopefully when those companies are big enough, there'll be enough of a competitor, at least in those smaller markets, that maybe the big boys would get involved, which would be nice. Questions? Any other? Anybody? I have other questions, but if you're the important people.
I have a website. The question is, where do I get my funds? I have a website, and people donate through that, and I have some foundations and some individuals supporting me. Even there's a hedge fund that supports me now. There's a hedge fund like sponsors 8 kids a year.
Wow.
That's cool.
Yeah.
Great.
So is that the future? I mean, we've just said philanthropy 3 times in the last 2 questions. Is that where we're going to end up relying on for all our work, do you think?
You know, I think that to a certain extent that philanthropy may get it started, but the hope would be is then the philanthropy starts and then it can be sustainable. The work we did in Calcutta, we started off with churches from the US and Canada supporting X number of surgeries while I trained the plastic surgeon and oromaxillofacial surgeon there to do them. At that point, then we go with another philanthropic group with Smile Train, who supports the local surgeons with, get this, $250 per case, but that pays for a week in the hospital, the surgeon and anesthesia fee, maybe a little bit extra if we have to do blood work. So, you know, again, what's happened is now from us doing, you know, someplace between 16 and 20 cases per visit. Now they're doing 500 cases per year. Now, but the philanthropic mission there is now, the mission hospital is at is now put in 2 new operating rooms, which are bringing in additional revenue, and has made them one of the few cleft teams in the entire city of, I think now, close to 20 million people. So again, I think that sometimes the philanthropic helps get things started, and you have to think of that when you get started in some of these things. But again, trying to make it sustainable so that it's not just in my opinion, the person flying in to do the surgery, but it's something that's going to be sustainable for years and years and years to come.
Do you have something to say?
Go ahead.
You know, spine surgery is a big deal, and it takes a long time. It takes a long time to train somebody, and it's expensive. It's relatively expensive, much more expensive than, say, cataract surgery or cleft surgery. So it's more labor intensive, and it's more difficult to fund. And it's something that I'm aware of all the time.
So the topic of this this section is the surgical ecosystem, and I know that we don't necessarily have a clear view of what that actually is. I know that Catherine and myself and some other folks are trying to look into that and figure out what makes up that surgical ecosystem. Do you think that it's going to be possible, and I'm being deliberately stimulating here, do you think it's possible for us to take our ecosystem model, surgical ecosystem model, and template it down into a low-resource world, or what do you think needs to change in that transition in the next 5 minutes?
Only 5 minutes to
Yeah,
change it.
yeah.
I think, you know,
no adjectives.
Dr. Cotton's talk about the essential surgical procedures, there are parts of that ecosystem that are essential. You know, for me to go anywhere and operate on children, I have to have capable pediatric anesthesia services. I have to have sterile instruments. But a lot of the things that we take for granted and we do here and we invest a lot of time and effort in don't add, you know, a lot. I think you have to boil it down to the basics in terms of that ecosystem. And there are some things, you know, in terms of prep solutions, you can mix 5% povidone iodine in 55-gallon drums. And it works for just about anything that occurs topically with an eye of an infectious nature, as well as anything we have here. You know, there are certain things that we may be able to do better there because of fewer restrictions. And I must say, with all of the things that we go through in varying countries, the infection rate after eye surgery done in developing countries is very, very low. I don't think it differs much at all from what we see here with everything we go through.
Thank you. Dr. Hodes?
I agree with what you said. I mean, you clearly need especially with spine surgery, you need very sterile technique. The rate of infection in the United States is about 2.1% after spine surgery. The rate of infection in Ghana is actually less than that at Dr. Boachi's hospital. So it can actually be done. It can be done well at a low cost.
Yes, absolutely.
But that's with Dr. Boachi sort of setting the stage and making sure that it's done well, because when we were using Corlebu, the university hospital, the infection rate was higher.
Well, you do need to take control of things, and someone has to take responsibility. The one thing I've learned in many different settings is having somebody take responsibility for what is being done, rather than having it be a committee, all thinking someone else is doing it, is essential to making things happen. Whether it's effectively planning surgery and just orchestrating the day, or planning anesthesia for a child.
No.
And I think one of the more important things is that regardless of where you are, what you're doing, and what your training is that, you know, safety has to matter. And that means is that whether you send somebody out because you're not going to be able to handle that kind of surgery in your place, or whether it means you're doing something very simple, but if you do it poorly and now that person is harmed by what you've done or you've attempted to do, we have to pay attention to that. And so that means that whether you're in a low-resource environment or a high-resource environment, you have to think about, how can I make sure that this is the safest that it can be, so that you prevent complications before they happen, and if there is a complication, take care of it in an appropriate manner.
Thanks. Well, I think we're done with the time. I want to thank our panel. Thank you for your great thoughts and speech. And I'm honored to be on the stage with you.
Thank you.